And good afternoon, everyone. Welcome from St. Louis, Missouri, and the home of the Missouri Institute of Mental Health. My name's Tom Pansella. Thanks for taking the time to join us. We're joined by Dr. Eric Hart from the University of Missouri, Columbia, and I'll introduce him to you in just a second. I want to give you a couple of items, though. Welcome back to those who have been here before. As you know, we offer CEUs on programs like this, and there's a link at the bottom of the page there if you'd like to get CEUs. They're $10 a person. The program content's free. The CEUs cost you just a little bit. We've also just released a traumatic brain injury DVD with Dr. Tom Martin. Some of you may have seen him when he was here with us. Dr. Hart tells me that I'm supposed to say that he actually knows Tom Martin. But that DVD is available. I just released that this morning, and we'll have a special offer related to that. We'll let you know about that at the end of the program. Dr. Eric Hart is also going to be presenting at the Brain Injury Association of Missouri's annual conference, which is just a couple of weeks away. You'll see a link to that association and to their conference also at the bottom of the page there, as well as a link to a PDF version of the slides that he's using today. And so you'll be able to see them in the window, in the video window itself, but you could also see them in a pop-up window if you like, or to hold on to them for later. And so, Dr. Eric Martin currently serves as a clinical assistant professor for the University of Missouri Columbia Department of Health Psychology. He is also the psychology consultant to the sleep medicine program at MU. He earned his professional training at various facilities in Illinois and Missouri. He's given numerous educational presentations, has been published in professional publications, served as a professional reviewer for various publications. And Eric, thanks for joining us today.
Thanks.
The floor is yours.
Okay. Hello, as Tom said, I am Eric Hart. I'm a clinical assistant professor in the Department of Health Psychology at the University of Missouri Columbia. And for the past 5 years, I have worked primarily as an inpatient and outpatient rehabilitation neuropsychologist focused primarily in treating survivors of traumatic brain injury. And what I want to talk about today is vocational outcomes following traumatic brain injury. Tom was mentioning the Brain Injury Association conference that is coming up in just a few weeks, and I'll be partnering with one of my colleagues, Dr. Stephanie Reed-Arndt, and we'll be talking about this very same topic. I want to sort of introduce to you what my objectives are for today. I want to increase your awareness of some of the demographic factors that are associated with vocational outcomes following a traumatic brain injury. Also want to increase your knowledge of the roles of comorbidities, and what these are referring to are the multiple disabilities, psychological factors, and what effect that they have in predicting successful return to work following a brain injury. I also briefly want to introduce some current models of vocational rehabilitation and finally reference some of the current research on interventions that can be used to improve vocational outcomes. And I want to point out that the latter two objectives are really going to be discussed in more detail during that conference that's coming up in just a couple weeks. But this is, in essence, to set the stage for what we'll be talking about at a later date. First, I want to talk about some of the incident rates of traumatic brain injury. Traumatic brain injury has really become an important public health concern in the United States. And some of the information that I pulled from the Center for Disease Control estimates that about 1.5 million individuals sustain a traumatic brain injury each year in the United States. Of those, 275,000 are hospitalized, and about 52,000 result in death. Also, about 1.36 million are treated and released from the emergency department. And it's important to also point out that we really have to interpret the incident rates of traumatic brain injury with some caution, because many of the cases, primarily those that are more mild levels of severity go unreported. I also want to point out too that much of what I'll be focusing on today is really most applicable to survivors of brain injury who have more of the long-term consequences. So really this is referencing more of the moderate to severe levels of injury. When we talk about traumatic brain injury, we see that there are some gender differences. What rates have shown that traumatic brain injury occurs about 1.5 times more frequently in men than women. We also see that there is what we refer to as sort of a trimodal distribution. So there are really 3 distinct age groups that traumatic brain injury occurs more frequently in. I want to also point out that there's some different causes within the different age groups. So on the young end, from the 0 to 4, and then more affecting the elderly, 65 or older, we tend to find that falls are the leading cause of traumatic brain injury within those groups. And that middle age range, the adolescent to early adult groups, we're finding that motor vehicle accidents really remain as the primary contributing factor to traumatic brain injury. Also, just about 500,000 ER visits per year for children and adolescents up to the age of 14 are accounted for by traumatic brain injury. The CDC released some really interesting information a few years ago, and they state that about 5.3 million Americans currently have long-term or lifelong need for assistance with activities of daily living due to TBI. About 40% of those hospitalized had at least one unmet need up to about 1 year after their injury. And I wanted to point out what some of those unmet needs were. Talking about the need to improve memory, problem solving, managing stress and emotional upsets, controlling one's temper. And I think this kind of all relates to that final point, improving one's job skills. I think what's interesting about this is these unmet needs really tend to center around those neurobehavioral consequences of brain injury. Surprisingly, less prominent are the physical unmet needs for this population. When you look at the literature that talks about life satisfaction, we really see a pretty clear correlation with work and life satisfaction. And this, of course, exists within the brain injury population and the non-brain injured population. It's really kind of across the board. When we look at success of modern comprehensive inpatient, outpatient rehabilitation programs, a lot of what we find is the ultimate measure of success, of course, is helping a survivor of brain injury reintegrate back into the community, and really return to work is often regarded as the greatest measure of success for rehabilitation programs. Occupation is described as a critical aspect of daily life and can factor both positively and negatively on someone's overall health conditions. What I want to point out in this last point here, disruption in returning to employment or even an academic status following a brain injury can certainly be quite distressing for the individual, but I also want to point out some of the other systems that are involved. Research clearly points to the disruption that this can have in social systems as well as family environments as well. So this is produces the inability to return to work and can cause stress for the survivor of the brain injury, and it can certainly affect other systems as well. Over the past several years, we have seen that survival rates following brain injury have increased considerably, and this is due largely because of the advancements in treating the early stage complications of brain injury. Now, the effect that this has had is that this is creating an increased demand on community resources, and primarily a demand for those counselors that are focused on helping the survivor reintegrate back into the community and then as well back into the workforce. When I was putting together this presentation, I was looking at some of the historical accounts of vocational rehabilitation and how things have evolved over the years, and I was and what comes to mind is a chapter that I had read fairly recently that references kind of around the 1970s when vocational rehabilitation really kind of started to come into vogue, and the focus at that point was primarily assisting individuals with ways of circumventing and accommodating for physical limitations. And they draw a really interesting tie into how the increased survival rates of traumatic brain injury has really sort of changed the scope and the focus of vocational counselors. And what we're seeing as of more recently, the vocational counselor typically now has the task of focusing on not only the physical consequences of disability or traumatic brain injury in this reference point, but also the myriad of emotional, behavioral, neurocognitive, and social implications that goes along with survivors. TBI undoubtedly has had a significant impact on the U.S. economy. Some of the data that I found indicates that about $9 to $10 billion is spent each year on persons with traumatic brain injury in the U.S. alone. Of that $9 to $10 billion, $2 billion per year is spent on vocational rehabilitation services. When you look at unemployment rates across the country following a traumatic brain injury, you're going to see a lot of variability. And a lot of this is based on how employment is defined in these studies. For instance, some studies will point to volunteer work or work in sheltered workshop settings as considered successful return to work, as where others will focus exclusively on the competitive job market. Further, National Institute of Health estimates that 70 to 90,000 persons having persistent TBI-related deficits each year results in almost $650 million lost in annual income, about $96 million lost in taxable income per year, and about $350 million is resulted in increased public assistance per year. I wanted to point out some historical trends in vocational rehabilitation services. I was looking at some data that referenced some historical trends over about a 9-year period. And in 1995, state VR programs provided services to about 1.2 million individuals with disability. Now, in 2004, this data suggested that a little over 600,000 persons in the U.S. requested services, about 500,000 were eligible, and half of that, a little over 200,000, were successfully employed. 95% of those were involved in competitive employment. Given the clear economic impact or financial impact, burden, what have you, that traumatic brain injury has on the U.S., researchers are now spending lots of time focusing on what some of the predictive variables can be for successful return to work following a traumatic brain injury. Age has been found to be a significant predictor for return to work, in that younger survivors of brain injury typically have a more favorable prognosis for return to work. A higher premorbid education predicts more positive return to work as well. And what we also find is that vocational rehabilitation services are often more available to those that reside in some of the urban areas. And I'll be talking about this in just a little bit. Those that live in the urban areas tend to have more successful employment outcomes. Conversely, rural clients, and I'm going to be talking a little bit later about how this applies to the state of Missouri, often receive less DVR services, and they in turn are going to have poor outcomes. And really this is sort of what we would expect due to a number of different environmental factors. Primarily, this is due to the limited job opportunities that are available in those rural areas. There's limited access to rehabilitation services, professionals. I can attest to my clinical practice in Columbia, where we have a very wide catchment area. There are a number of our folks who are coming a great distance to get their rehabilitation needs met, and many of them, of course, are limited by transportation burdens and what have you. Other environmental factors, of course, relates to transportation. And I'll talk a little bit more about some of these things a little bit later on. So, some of the gender differences. Men and women with TBI tend to receive different VR services. Now, this is despite similar injury severity, other demographics, and even similar neuropsychological test scores. And it's been speculated that the reason for this difference really is due to different societal expectations. So there may be a focus on women being primary homemakers or parents or other types of expectations that are more culturally based. Ethnicity is an important variable to look at. African Americans and Caucasians have similar vocational outcomes, similar return to work outcomes. African American clients tend to receive more services, and this seems to be more so related to the fact that African Americans, at least the studies that I've looked at, tended to reside more in the urban areas and again had more access to services and presumably even more access to job opportunities. Within the state of Missouri, those that were receiving services through the Department of Vocational Rehabilitation really experienced success working with, those of racial and ethnic minority groups did experience success when working with the Missouri Department of Vocational Rehabilitation. So the results were really promising for ethnic minority groups. Kind of going back to the idea of age here, it's important to point out in looking at the data nationwide and even within the state of Missouri, what I found was that survivors of TBI at different ages had very similar, often very similar to other demographics, injury severities, and neuropsychological characteristics. And what was very promising is that individuals of all ages appear to benefit equally from DVR services. And as a treatment provider, I can say that this finding is also very encouraging. I've had a number of patients that I've treated following a brain injury, and we talk about community reintegration, and my focus may be wanting to have this individual reintegrate back into the community or back into the workforce. And one of the common statements that I get is, well, what can vocational rehabilitation do for me? I'm kind of past my prime, and can they really help me here? And what was encouraging to find that specifically in the state of Missouri, individuals of all ages, again, seem to benefit equally. It's an important piece of information to carry around. So some other predictive variables that were found to correlate with success and return to work following a traumatic brain injury. Those that were employed at the time of their injury really had a higher rate of success in returning back to the job force. Those that had continuous employment especially. Those that had higher education had greater success. Those that had less physical disability. And I think what also is very important is to point out this history of substance abuse. So those that did not have a history of substance abuse were actually found to return to work they were 8 times more likely to return back to the workforce following a brain injury. Some other predictive variables. Those that spent less time in the hospital, that probably, it probably goes without saying that would correlate mostly with level of severity of the injury. Those that had less neurobehavioral changes. So those are the folks that tended to have more behavioral control, were less disinhibited, were able to regulate their emotions a little bit better, and certainly had more intact neurocognitive functioning, better memory, better processing speed, problem solving, things along those lines. More accurate self-awareness. It's not uncommon following a brain injury for an individual to not have full understanding of what their limitations are. And those that had a restricted range of understanding what their limitations were, not surprisingly, had a lot more difficulty returning to the workforce. And I presume were less willing to accept rehabilitation services, job accommodations, and so on. Members of minority groups, unmarried, and then those that were able to drive, return to driving following a brain injury, clearly predicted employment stability. Yeah.
We have had a question come in, and I would encourage people to use the chat link underneath the video window. You'll see the questions that have come in here. And this person asks if you have percentages for African Americans versus whites regarding the numbers of TBI, rather than simply saying that the African American increase in vocational rehab services are because they tend to live in urban areas.
I actually do have some data that I can incorporate in the presentation that will be given in a few weeks. There are some real specifics that have come from the state of Missouri, so I can incorporate those at a later time. I don't have them included in this presentation.
Thank you.
Okay. Okay. As a rehabilitation neuropsychologist, I certainly spend a lot of time looking at neurocognitive variables and trying to make predictions about future functioning, community and reintegration, and certainly return to the workforce. And when we look at the literature on neuropsychological predictors for return to work, from more of a neurological perspective, it seems fairly obvious that injury severity is going to impact return to work. So those who have a more severe injury are going to have more difficulty returning to work. When you look at more specifically some of the neurocognitive domains, really the preponderance of data points to IQ, memory, visual perceptual motor skills, ability to process multiple sources of information simultaneously. Also executive functioning, so someone's ability to problem solve, organize, and plan out behaviors, follow through with things, learn from environmental feedback, and so on. I think that kind of makes sense, and we see dysexecutive syndromes really serve as a very poor prognostic indicator for return to work. Psychological adjustment, it is no secret that traumatic brain injury puts someone at a higher risk for a multitude of different psychiatric conditions, the most common being major depressive disorder, followed by some of the anxiety-based disorders. Those can certainly impact someone's ability to maintain stable employment. I wanted to point to a really interesting study that came out of the University of Missouri a little while ago. Johnstone and colleagues sort of took on a new way of interpreting neuropsychological data and really focused on premorbid levels of functioning. Historically, we have looked at absolute scores and try to determine what effect this is going to have on someone's ability to return to work. And what by that I mean someone who has more neuropsychological impairment, we would assume that they would have a less favorable prognosis in returning to work. But this study that came out a few years ago changed things up quite a bit. And looking at someone's premorbid level of functioning was really found to be a better predictor of return to work than looking at absolute scores. So in other words, the study suggests that considering relative decline, so what is the amount of decline that has occurred compared to pre-level or pre-morbid, pre-injury level of functioning was a much better predictor. So it really sort of changed the way that we interpret neuropsychological data when making predictions about return to work. A little bit of a technical difficulty here. I want to talk about some comorbid issues. This piece of information is coming from some of the data that was found in the state of Missouri. And persons with TBI and concomitant psychological and academic abilities appear to have significantly worse vocational outcomes than those persons with TBI alone or TBI and physical disabilities. And sort of the reason for this is it seems to be easier to accommodate for some of those physical disabilities, assisting the patient with using, or the client rather, with canes, splints, assistive technologies versus psychological difficulties. And this really kind of speaks to where we can go from here. What are some of the things that we can offer as service providers to increase someone's likelihood in returning to work following a brain injury? I want to point this out too. Demographic and individual variables predict vocational outcomes, but so do the services provided. And what's so very important about this, I've presented to you a number of different demographic variables, individual variables, many of which are non-modifiable. At this point, post-injury, that would include severity level of the injury, certainly gender, age, and so on. But what is encouraging is that some of the modifiable things that we can do can be incorporating different types of interventions. And the bottom line is vocational rehabilitation services are effective and they're cost effective. So what can be done? Preparing an individual to return to work following a catastrophic injury often requires an interdisciplinary team approach. We could spend a whole lot of time talking about the physical, the emotional, the cognitive, the behavioral consequences of traumatic brain injury. Suffice to say that there is a multitude of consequences that can happen immediately following the injury and can be enduring for a survivor for several years post-injury, and some are even lifelong. Having said that, it would make sense that we would want multiple providers to be involved in care. Traditional models of rehabilitation really focus on restoring the best possible level of functioning and hopefully improving someone's quality of life and facilitating community reintegration. I want to talk about sort of what was found a couple of years ago in some of the studies that were carried out at the University of Missouri through the TBI model systems that was done in collaboration with the Department of Vocational Rehabilitation. So participants were looked at participants at 1 year post-injury were found to evidence a decreased employment rate of about 55%. Unemployment increased 425%, and of course income declined about 51%. No surprise here, of course, public assistance was then increased about 275%. So who was the typical Missouri vocational rehabilitation client, or what were some of those common demographics? They tended to be the relatively young white male, and if my memory serves me correctly, sort of within that 30 to 35 year age range. Limited education, I believe the average is about 11 years of education, so the average was a non-high school graduate. Fairly significant traumatic brain injury, so these were the folks that were more within that moderate to severe range. Those that had sort of a low average intelligence with commensurate memory, and had a number of different neuropsychological deficits, primarily in reasoning, mental processing speed, divided attention. And these were also folks who were several years status post-brain injury. I believe the average was around 9 years post-injury. So how successful were these services? 17%. The case was closed and there was successful return to work. 10% were unsuccessful. Service was interrupted for 13% for a number of different reasons. This is a fairly alarming statistic, and I want to make sure that I explain this in appropriate detail. So 60%, the cases were closed and no services were provided. And the reason for this, I must point out, is the common causes were the client's refusal to participate, or they were being uncooperative. So it had less to do with the service that was provided to them and more about some of those individual differences. So more state-specific data. What were those things that predicted success? Well, let me back up. What were the types of jobs that these individuals had? 50% were employed in industrial jobs, 14% were employed in fast food service, 14% in sheltered workshops, 7% in clerical positions, and 7% in professional positions, and 7% we didn't have the available data. So going back to what I was saying earlier, what were some of those predictors for success specific to the state of Missouri? Injury severity, that hangs together pretty nicely with what we see in some of the nationwide data. Loss of consciousness, post-traumatic amnesia, hospitalization certainly had a clear correlation with return to work success. Also, some of those demographic variables, age, education, the neuropsychological test scores, and I want to refer back to that study that I was talking a little bit earlier from Johnstone and colleagues. It was more relevant or more significant to talk about that relative decline rather than those absolute scores. And VR services being provided, job placement, and on-the-job training were found to be very significant variables. And I want to talk about some of the findings that evolved from doing the odds ratio. So 14% was improved with counseling and guidance assistance. And most notably, on-the-job training enhanced return to work by 16%. Okay, so of course there's barriers that still exist. Now we have found that there are some things that we can change, there are some things that we can't change. Certainly the good news is vocational rehabilitation services can be efficacious. But what are some of the challenges that we have to face? And I just want to point out here that this is sort of setting the stage for the presentation that will be given at BIA. I wanted to really spend some time introducing some of this background information and then talking about services in a little bit more detail at a later point. What we want to do is we want to increase the access to rehabilitation services and professionals. And one of the things that we're starting to get involved more in at the University of Missouri is telehealth services. This can be critical for folks in more rural areas. Modifying other environmental factors, increasing transportation opportunities is going to be critical. Increasing referrals from minority groups. And then finally, addressing concomitant mental health issues. And this is certainly something that I can relate to as a provider of mental health services. We know in the field that different behavioral interventions, cognitive interventions, and even psychopharmacy can be very beneficial for survivors of traumatic brain injury. And the hope is that if we can provide them a service and decrease some of those symptoms, assist them with learning better strategies to control behaviors and so on, maybe we can increase return to work success. So at this point, I want to point out some of those that have been involved in this work. Certainly the collaborators in the TBI model systems, those projects that came out in the University of Missouri, Dr. Johnstone, Dr. Reed-Arndt, Dr. Shop, and I also want to point to an interesting website, the Brain Injury Guide and Resources. It is a very comprehensive resource for those that work with survivors of traumatic brain injury. And I also, of course, want to promote the Missouri Brain Injury Conference that will be coming up October 22nd through the 24th. And I've included the link to the BIA Missouri website. And at this point, I'd be happy to take any more questions that come up from any of our viewers.
And we would encourage people to ask questions. Do you have any questions in the room here with us? Use the chat window underneath the video window. You can click right next to that button that says Say. Type your questions in there and click on Say. Also encourage you, if you'd like CEUs for the program, those are available underneath the video window as well as a special offer with the DVD with Tom Martin. If you'd like to purchase that and the CEU at the same time, there's a special offer. You can get both of those for $25. We've linked to the Brain Injury Association conference and to their website down there. We'll try and capture this other link as well to send out in a follow-up email. I stalled just long enough. We've got a question come in here. It says, any coordination with the VA regarding statistics?
Not that I'm aware of. Not that I'm aware of. Again, a lot of the local data that I'm providing came exclusively from the University of Missouri's collaboration through the Department of Voc Rehab.
All right.
Yeah.
Cooperation, people coming for further assistance, and do they cooperate pretty much, or do they fall by the wayside?
Well, to kind of go back to that slide that references that 60% where Voc Rehab services were unsuccessful and the case was closed. The primary reason was the clients were uncooperative or refused services. So that really had a significant effect on return to work success.
We have a stats-hungry crowd out here.
Oh, goodness.
Do you have any stats on successes with folks who may have developmental disabilities or mental retardation and maybe brain injured or damaged?
I focused this presentation primarily on traumatic brain injury, and again, this research through the state was coming through the TBI model systems grant. So that was, the inclusion criteria was having sustained a traumatic brain injury. And that is my primary focus as a provider. I'm sure that data exists. I'm just probably not the one to comment on that.
All right. Well, Eric, it looks like we've done it for today. Did a good job. Folks, thank you very much for joining us today. Again, you can purchase CEUs. You can purchase the CEU in combination with the DVD. All that links below there. You'll be on our email list for having been a part of this. We hope you'll stay tuned to the things we've got coming up. You probably have noticed that the Department of Mental Health Spring Training Institute's also coming up. We've got a plug for that available to you. We're still looking for presenters, sponsors, and exhibitors. If you go to the main mimhtraining.com page or mimhtraining.com/STI, you'll see our call for presentations and sponsors and exhibitors for that program. Call for presentations open until the 24th of this month. We did a little checking. We found out that this is very likely our 100th free web conference since we started doing these about 4 years ago. And we really appreciate you taking the time to join us for all of these programs. Some of you have been with us for an awful lot of them, and we certainly appreciate that. So with that, we'll say goodbye to you. And Dr. Hart, thank you very much for your time and your expertise today.